Uday.
Sure. So this is the best thing I like about this. The best clinical decisions are at the heart of appropriate care, the goal to which a system should aspire. So the clinical decisions are what are most important. And to arrive at clinical decisions, we need a sound knowledge of the physiology and biochemistry of the particular disorder, and not just go by what reports we are seeing on the lab sheet. This is just a very brief thing. Don't go too much into it. But what I want to say is that, like everything in endocrinology, the thyroid axis, which consists of the hypothalamus, which, as you can see here, one second, let me just bring up a pointer. Just a second for this. Yeah. So as you can see here, the thyroid axis basically consists of the hypothalamus, which secretes what is called the TSH releasing hormone, followed by the pituitary, which secretes the TSH, followed by the thyroid. These are the three important things in the thyroid axis, and they have what is called a servo control mechanism, which means that if the thyroid even slightly under or over produces the thyroid hormone, which, as you know, is so important for all body functions, there is an immediate action on the hypothalamus. The TRH either goes up or down, as is the case. That modulates TSH, and that tries to change the TSH and T4. So we never look at T3, T4 alone. It is always, as in endocrinology, it's a paired test. So T3 and T4 always goes with TSH. This is a very important thing to be remembered. If you look at what the thyroid produces, predominantly what the thyroid produces is T4, not T3, except in hyperthyroid situation. So in normal person, the thyroid actually produces approximately 100 micrograms of T4 every day. Now, this T4 is not the biologically active hormone. In the peripheral tissues, T4 is converted to T3, and this T3 is then deactivated to form the inactive hormone, or something called the RT3, or the reverse T3. So remember that T3 is the product of peripheral conversion of T4. Always remember that. And it is the T3 which is biologically active. And also remember that T3 and T4 never circulate in the blood as T4 and T3, but they are biologically inactive like that. What is active is the free T3 and the free T4, which is independent of protein binding. So T4 and T3 are bound to proteins. But once they are freed of that protein binding, what we get actually is free T3 and free T4, which is then available for action on the tissues. Now, I was talking about this servo control mechanism, and what does it mean? So this graph actually explains what this really means. You will see here that the TSH range is quite large. So it could be somewhere from 0.5 to, let's say, about 5. And in this range, the TSH is all normal. Now, the T3 and T4, even when the TSH is relatively normal, the T3, T4 have a wide variation. Now, even if the T3, T4 go a little beyond normalcy, for example, from this normal range, the T4 goes a little high, you will immediately see that the TSH goes higher. If the T3, T4 go a little higher than this particular range of normalcy, you will immediately see that the TSH starts going down. So basically what I'm trying to say is that an X change in T4 translates into a 10X change in TSH. So what is important for us, really speaking, in thyroid disorders, more than T3, T4, is the TSH, because the TSH is the first one to respond to even a minute change. As you can see here, even in this so-called normal range of T3, T4, a little change from normalcy on the either side will result in either an elevation of TSH or a reduction in TSH. This is something which is very important. And therefore, always look at TSH first and then look at the T3 and T4. Now, as far as the diagnosis of thyroid disease goes, the problem nowadays is that there are so many labs doing thyroid hormones and so many people doing thyroid tests. So any symptom now, you ask patients, why did you do the thyroid test? I was having some cramp. I did a thyroid test. So that may not necessarily be the cause of his problem. And thyroid tests are so commonly done that you have a whole lot of borderline thyroid values, which can become very confusing. In its most florid form, so when a patient is getting severe tremors, losing weight, his eyes are popping out, there is a big goiter, he's got tachycardia, then, it's very obvious that he's got hyperthyroidism. On the other side, a very puffy, dull-looking, morose patient, dry skin, very slow reflexes, ataxic speech or dysarthria, slurring of speech, heavy speech is typical hypothyroidism. But there are so many in between which have slightly borderline thyroid values where, actually speaking, we need to be very careful. So it is in these middle cases that the whole clinical spectrum actually starts off. And I don't know if you can see the slide here, but there are so many situations. For example, you have a situation where the FT3, FT4 is clearly elevated, TSH is low. I told you, this is typical thyrotoxicosis. On the other hand, if the FT3, FT4 is very low and the TSH is very high, it is typical hypothyroidism. But then you have a scenario which you often see where the TSH is marginally increased, the FT4, FT3 are relatively normal, and the signs, symptoms are very plus minus. This is not overt hypothyroidism, but this is a very borderline kind of thyroid dysfunction. On the other hand, you can have a normal FT4, FT3 with a little drop of TSH, and that is called subclinical thyrotoxicosis. So you have gray areas in between, and not all the time do you have very classic hyperthyroidism or very classic hypothyroidism. Remember that always. And then you have a situation sometimes where the TSH is not elevated. In fact, it is low, but the FT4, FT3 is very low. Normally, what do you expect when the FT3, FT4 goes low? You expect the TSH to go high. But when it doesn't go high, you're basically thinking of a central cause. That means a pituitary tumor, which is not allowing the TSH to adequately go up. And yet the T4, T3 is down. So you have a lot of things, plus there are so many drugs. I cannot, in this next half an hour, take you through all the cases, but we will try and cover some important points. So euthyroidism means normal T3, T4, normal TSH. Hyperthyroidism means high T3, T4, low TSH on this side. Hypothyroidism means low T3, T4 on the y-axis, and x-axis TSH going high. So remember at least these three important things. Okay, and then we move on. And this is how it will look. And remember that TSH is one of the most sensitive indicator of thyroid disease. Please remember that. And now we go on to cases after this particular discussion. And whenever there is a doubt, please stop me, ask a question. Don't feel shy, whatever it may be. Don't feel that this is a very silly looking question. No, please ask anytime. So this is a 40-year-old patient. He's working with a national bank as an executive. He's been diabetic since 2 years and taking metformin. He presents as is typical. Most of the times they go for some tests in the lab every year, and he comes back with a hemoglobin which is normal. The fasting glucose is 90, the postprandial is 120, HbA1c is well controlled, but his TSH is 7.8 microunits per ml. Now, there are different ranges given in different labs, but for the purpose of today's lecture, let me tell you that a range between, say, 0.5 to 4 is considered as normal. Okay, So this is slightly on the higher side. His total cholesterol is 220. We don't have the other parts of the lipid profile, and I think that's not a very ideal situation. We must have the LDL, we must have triglycerides, HDL, etc. And his history is actually mild lethargy. Now, as you can understand, mild lethargy is such a common symptom. It has no real meaning. He could be actually getting tired because he's overworked, or because he may be obese, or because he's not exercising, or he may be depressed. There are so many reasons for becoming lethargic. This is not a very specific symptom. Now, what is the next step? Would anyone like to actually intervene and tell me what you would do? If anyone is willing to take a call.
Sir, wait and watch and repeat the test after 2 months or maybe 3 months.
All right. So one option, as you said, is don't do anything. The TSH is 7.8. Just wait and watch and see what happens. All right. Why would you do that? Why? What is the rationale? And how many of you would start treating immediately?
As he is not having any major symptoms.
Yes.
And this mild symptom can be because of some other problems also.
Right.
So,
as I said,
there
correct.
is no reason of becoming aggressive in treating the patient.
All right. Very good. So there is no reason for becoming aggressive in treating this patient. Are there any other different views on this issue?
We can do thyroid antibody this particular person.
All right. Very good. You can do thyroid antibodies in this particular patient. Why would you do thyroid antibodies? What would be the, how would you use it in treatment?
So if he is having thyroid,
Yeah. Yes. Go on. Sorry, I can't hear you.
Rule out autoimmune.
Rule out autoimmune. But so let's say the antibody is negative or the antibody is positive. Does it help you in deciding on treatment?
Sir, if antibody is positive,
Yes.
chances of getting hypothyroid are very high in future.
Very
So
good.
in future, he is going
Excellent.
to get
So
some
if the
medicine.
antibodies are strongly positive, the chances that he will progress to overt hypothyroidism are very much higher than a person whose antibody is negative. Tell me one thing. Is it that if you just repeat this TSH after 2 or 3 months, or even 1 month, or even 1 week, it could be different?
So maybe.
Is it possible? It is very much possible. And TSH levels without any intervention can change by up to 35%. So, yes, I agree with both of these steps. Does anyone want to start treatment right away? Is there any taker for starting the treatment right away?
Hello.
Hello, yes.
Sir. If only if TSH is it is 7.8,
Yes.
and if TPO antibodies are positive, then
Yes.
only we can consider starting. But if
Yes.
TPO antibodies are negative, then no need to start treatment.
Yeah, but you see, I mean, you will agree with me that most patients will tell him that, oh, this is very high, asa tasa, and you start treatment. So is there anyone here who would like to start treatment right away? And what
No.
is the
Sir,
rationale?
if patient is symptomatic, definitely we should start.
So this is the symptom which is in front of you, mild lethargy.
Okay.
So now
No,
tell
Sir,
us.
in this.
Sir, if patient is obese, patient is having dyslipidemia and
Okay.
uncontrolled sugar also. So in
The
that
sugars are controlled.
in this case, but
Yes.
if he is having dyslipidemia of other LDL which are not given,
All
so
right.
in that scenario, we may think of starting with the mild dose.
Very good. So this is another thing which is coming up. So we had 3 or 4 scenarios. One was do nothing, wait and watch. One group said do a TPO. If it is strongly positive, start treatment. Someone else said that if the lipids are elevated, if he's gaining weight, and if he has a few symptoms, no harm in trying treatment. Excellent. I am very glad because all of them are absolutely correct responses. Would you like to do FT4 in this particular patient? Well, actually,
Yes, sir.
if you would like to do FT4 in this particular patient, or would you like to do FT4 and antibody? So by and large, let me tell you that the FT4 in such borderline cases would normally come out to be normal. However, if the FT4 comes low, then you are justified in starting treatment, because then it is actually going into slightly clinical hypothyroid state. So if at all you were to decide, if I want to do some more tests to decide what to do, you could do FT4 and antibody. All right. Am I clear?
Yes, sir.
Yes, sir.
Yeah. Fine. Excellent. So let's say this patient, we did a FT4 and antibody. Okay. The FT4 came out to be normal. The antibody came out to be normal. Now what next? Now the next step is, as we said, we could just repeat after 4 to 6 weeks. We could just start levothyroxine, monitor. Now, in this case, it was just decided to repeat the TSH because everything was normal and therefore nothing was started. And you can see here that from 7.8, the next TSH in the same lab came out to be 5.8. And this is what I was telling you, that in people who have been followed up over 12 months, you will see here that there may be up to a 50% change in TSH without starting any treatment. So rather than label someone for life with a diagnosis like hypothyroidism, it might be wise in such cases where there are hardly any symptoms to check and see what happens. But there are some caveats. Someone talked about dyslipidemia as well, and we will come to that later. Now, why did we measure FT4 also? There are certain conditions in which measurement of TSH alone. So let's say this patient had a lot of symptoms of hypothyroidism. He was becoming slow, he was becoming dull, there was dyslipidemia, his reflexes were slow, he had bradycardia, but his TSH was not elevated. And where can this be misleading? When basically we are dealing with central hypothyroidism. As I told you, the FT4 would have returned as very low. So remember that if you are finding a clinical diagnosis of hypothyroidism, he looks hypothyroid, but TSH is not elevated, always remember to do a FT4 also in that particular case. The other scenario where you will find a result like this, that means low FT4 and a low or non-elevated TSH, is when you try to do thyroid function tests in ICU settings. So all of you are physicians, all of you must be attending to critical cases. Please remember that if you order a thyroid test in ICU settings, and unless that TSH comes out to be very high, indicating some kind of a myxedema coma, for borderline thyroid levels, please don't react, because TSH and T4, FT4 all change in ICU settings. Please remember that. Let's take another scenario. The same patient, age 40 years, working with a national bank, known diabetic, the rest of the things are the same. And here the FT4 is decreased and the TPO antibody is clearly positive. And then the decision comes as to why then the TSH is not going up. Now here the FT4 is also decreased, so the TSH should have reacted. And one such reason is that if you are treating the patient with metformin, the TSH tends to go down. If you stop metformin, you'll find that the TSH goes up quite high. So remember that one of the drugs which changes TSH is a very commonly used drug called metformin. This is the point that I'm trying to make. So in these patients, when the FT4 is decreased, TPO is positive, even if the TSH is borderline, you're justified in treating this particular patient. The TSH was not going high, mainly because the person is also on metformin. So here you would start. And when you start, how do you start treatment? For a adult patient, you would start with roughly about 1.6 microgram per kilogram per day. And this is one mistake which I often see being made. So the patient is 80 kilos, but he started on 50 micrograms. No, for overt hypothyroidism. Okay. What would be his dose? 80 multiplied by 1.6, which would be come to somewhere close to 125. So don't start with 50 or 75. Calculate the dose. In pregnant patients, please do not waste time in starting with 12.5 and then going to 25. We don't have time. Start in overt hypothyroidism. If the TSH is very borderline, that's a different story. But in overt hypothyroidism, that means TSH more than 10, 20, always start with a larger dose, which is 2 to 2.4 micrograms. In elderly patients, you are justified in starting with small dose. So are you in patients with ischemic heart disease, particularly those who are prone to arrhythmias. I'm not going to go into newborns and children because most of you take care of adult patients. So be realistic, start with the correct dose. It will save you time. Patient will become asymptomatic much earlier. Now, there are patients who, despite a good dose of thyroxine, okay, continue to have high TSH results. So you have given him the correct dose, and yet the patient's TSH is not coming down very well. And what would you look at in such scenarios? I want you to comment from your own experiences. So let's say the patient is regularly taking 100 micrograms of thyroxine based on his body weight, and the next time he comes back with a TSH, he's still not completely normal. What would you suspect? Please comment.
Sir, I have seen those patients who are on PPI given simultaneously thyroxine and PPI, pantoprazole like drug. So
Yes.
their TSH keeps on rising only.
Excellent, excellent. So this is one of the very important drug interactions, PPIs, which are very, very commonly used. What else? Does anyone else have any personal experiences?
Calcium and iron tablets also disturb the absorption.
Very good.
commonly.
So very good. So calcium and iron taken simultaneously along with thyroxine clearly reduce the amount of absorption. This dietary soya thing is a bit funny. Okay. If someone is taking a bottle of soya milk every day with the thyroxine, it will interfere. Otherwise, the normal soya intake sometimes during the day will not actually change very much. What else? The other thing to see is whether he is taking the drug and keeping a gap of at least half an hour between the drugs and the food. Because if he takes food immediately, there will be some degree of loss of these particular drugs. And the last thing to remember is that if the patient has malabsorption, something like a celiac disease, he will not absorb his drug very properly. So always look at whether he's taking the drug, whether he's missing doses, whether he's keeping a gap between his drug and the meal, whether he's taking any other drugs which might interfere. And then also there are on the other side, you see that you have given the correct dose of thyroxine, and yet you're seeing that the TSH is actually changing and it is actually going down. And the most important causes for that are, as we said, metformin, physiological change occurring in pregnancy, dopamine agonists. This is important. And a lot of glucocorticoids, very important. And a lot of drugs which are used in cancer chemotherapy. So if you find that this patient is on multiple biologicals, particularly tyrosine kinase inhibitors and so on, please consult an endocrinologist, because there are many drug interactions which cause changes in the thyroid hormone. Excellent. Let's take another case. This is a 52-year-old male, 80 kilograms. He's a retail shop owner. He's a sedentary lifestyle. He's a known case of primary hypothyroidism on treatment. He's taking 112 micrograms of levothyroxine. You will see that for the last 3 years, 2016, 17, 18, his TSH has remained perfectly normal on whatever dose he was taking. In December 2019, however, he presented with symptoms which were suggestive of hypothyroidism, decreased T3, T4, and also elevated TSH. He says he was taking the drugs very regularly. His adherence was checked. No new medications have been added. No signs of GI malabsorption. He has not lost weight. There is no diarrhea, nothing. On what do you want to do? And then on this is a type of scenario that I want you to consider. Patient informed that he had gone to some dietitian and she started him on a morning routine of exercise, and she told him to take a glass of milk before leaving for jogging. And he was not keeping an adequate gap between his tablets and the milk, and this is typically what was causing the problem. So again, as we said, this is something that we must look at. I'm going to skip this. We can come back to that a little later. This is another case. A full-term normal delivery, weight 3.2 kilos. And as you can see, very weak bowel movements. And he was actually screened at pregnancy, at delivery, and he had nothing. But at 6 months of age, he started developing severe constipation and required laxative support every day. And along with the chronic constipation, he also had abdominal distension, failure to thrive, bradycardia, hoarse cry, macroglossia. You can see the whole colon is like a megacolon. And you can see here that the TSH is more than 100. Free T4 is very low. And of course here, as I said, the dose has to be significantly higher. We start with at least 4 or 5 micrograms per kilogram at this age. And if it is earlier, within the first 6 months, we start with 10 or 15 micrograms. And you can see here that while on treatment, he considerably improved and the whole abdominal distension all came away. So the point that I'm trying to make is that you have to do congenital hypothyroidism screening. So wherever you are coming in contact with pregnant women, please tell them that they must do a TSH of their baby after birth. Why so? Because congenital hypothyroidism is one of the most, or not one of the, it is the most important preventable cause of mental retardation. So please do this. There are different strategies for detection. I'm not going to go into that since most of you are adult physicians, so we will leave that alone. Another case, 87-year-old woman. She lives with her daughter and son-in-law. She has been diabetic for 20 years, hypertensive for 24 years. She has had a history of hip fracture 3 years ago. And the daughter is saying that she is becoming forgetful. The family has brought her to the clinic. You do a mini mental state, it's not too bad. Mini mental state examination is 25, and this is for your reference. It's pretty normal, but the TSH is 7.8. The normal being, again, as I said, between 0.5 and 4, and the free T4 is normal. Okay, so we have another situation now where the TSH is 7.8. Now, what is the best way to characterize her lab test? Is this subclinical hypothyroidism? Is this overt hypothyroidism? Is it a lab error, or is it normal for her age?
Normal for her age.
Normal for her age.
So everyone thinks this is normal for her age?
Yes, sir. Normal
Yes,
for
sir.
her age.
Yes, sir.
Wonderful. Any dissenting opinions? Anyone who thinks this can be labeled as hypothyroidism? Anyone who wants to say that this is hypothyroidism?
Uday, there could be this metformin. She is maybe on metformin, and therefore the TSH might have not been that high.
Okay, very good. We don't know what is the treatment strategy, but you're right. We said that, but we don't have that data. Let's say that she is not on metformin. Then what would you say?
Sir, as she is having a symptom of forgetfulness, so is it worth trying minor dose of thyroxine?
Okay, so that is what we are going to consider. That is the next question. So do you want to start a low dose of thyroxine and increase slowly?
Yes, sir.
Not start treatment and continue to monitor?
But
and
sir,
do nothing.
some says that low dose
Sorry?
to start minimum. Low dose doesn't work. In one webinar before from Hinduja, they said 12.5 doesn't work. At least you have to start with minimum 50. Is it okay?
No. So the question first is, do you want to start? If you want to start, then that's a different story. I told you start a little lower and increase as necessary. The question is, do you want to start? Do you first think this
Yes.
is an abnormal result?
Sir, it can be a
Symptoms are there.
subclinical hypothyroid.
No. See, what is subclinical hypothyroidism? Do you think this TSH is abnormal or is it normal for age? What is it? See,
See, normal
subclinical.
for age, sir, it is normal for age, but forgetful is there. So we must start with
We must try, sir.
So do
antithyroid.
you think when you become 87-year-old, you will remember this webinar?
No. Neuron degeneration
So
will be
obviously,
there
I mean,
at
a
the age of 87,
87-year-old
sir.
person is
Yeah.
likely to be forgetful, right?
Yes,
We
yes,
forget
sir.
things. Forget a 87-year-old, we forget
Yes.
things. And what is our MMSE? Is it showing any cognitive impairment?
No.
25,
No.
no.
No. So basically, what we have to understand is that as aging progresses, particularly after the age of 65 or 70, TSH, actually speaking, is not a very good marker and TSH starts going up. Okay. So typically, the TSH would go to about 7 or thereabouts. That is something which is very important. I want you to concentrate on this particular graph. So we are talking about this whole business of what is called subclinical hypothyroidism, right? Where the symptoms are not very convincing, the TSH is borderline high, and we are assuming that the FT4 is normal, okay? Now, if the TSH is 10 or higher, then there is hardly any controversy, you start treatment, okay? Now, if it is between the upper limits of normal, we said 4, okay, to 7, what do you do? If the patient is more than 65 to 70, just observe because TSH does go high with
काय
age.
करायचं वॉक करायचं
Sorry? Can you mute yourself, please? Please mute yourself so that others can hear. Yeah. So if the patient is elderly and the TSH is, say, between normal to 7, just wait. If the patient is less than 65 to 70, you can still wait. There are no convincing symptoms. If there are very convincing symptoms, then you may start treatment with thyroxine. This is in the group of slightly younger patients. And what happens between 7 to 10? Again, if more than 65 to 70 years of age, if there are no convincing symptoms, just wait and observe. The only place where now some people think that we should treat TSH between 7 to 10 is in people who are less than 65 years of age, and I'll tell you why this is done. So is this graph very clear to you? So we have 3 markers: more than 10, 7 to 10, and less than 7. Less than 7, by and large, you can observe. Between 7 to 10, if convincing symptoms of hypothyroidism, elderly and young patient, you may treat. But in age less than 65 years, some people now advocate treatment with T4. And as I said, this is again the same thing. You start elderly patients, your question which you were asking, you start with 25 to 50 micrograms per day. It's only when you have very severe ischemic heart disease and arrhythmias, you start with 12.5 and gradually build up. Is it very clear? Is this graph very clear? I want you to really internalize this because this is important. And why have people said that in this particular group? Because there is some evidence coming in now that in patients who are less than 65 and who have a TSH between 7 to 9 have a slightly higher chance of ischemic heart disease, and it will help them if we treat their borderline hypothyroidism. All right. So this is something which is very, very important. Now, this is a 50-year-old man with hypothyroidism. He started on sorafenib for renal cell carcinoma. He presents with new onset symptoms of hypothyroidism despite taking his dose of LT4 regularly, and his TSH goes to 55. Please remember, this is one of the drugs, as I was telling you, tyrosine kinase inhibitors, including sorafenib. They can do a lot of things. So some of them cause hypothyroidism, some of them cause hyperthyroidism. It's complicated. So best is to check with an endocrinologist about drug-drug interactions. What can we do for such patients? Just increase the dose of thyroxine. So this is something important. There are other drugs as well which cause increase in the requirement of thyroxine. These are patients sometimes on oral contraceptive pills, on phenobarbital and rifampicin. So these are commonly used drugs for epilepsy, for tuberculosis, as oral contraceptives, and you may find that the dose can go up. Amiodarone is a mixed bag. You can find both hypothyroidism as well as hyperthyroidism with amiodarone. So if the patient is on amiodarone, please remember that to screen for thyroid at least every 6 months. This is another case, 36-year-old housewife, known primary hypothyroidism on 75 micrograms of treatment. All through her reports were normal. Again in December, she started presenting with typical symptoms. TSH went up. The adherence was okay. No new medications, no signs of GI malabsorption. The only thing is she has started with a health drink, which was told to her by someone, and this is causing a slight malabsorption of a thyroxine. Uncommon scenarios, but nevertheless important. What can you do in such scenarios? Since she was taking the soy milk in the morning before her exercise, you can switch the thyroxine to nighttime dose, provided you keep a gap. So you have to tell her to eat at 8 and take the thyroxine at bedtime, that is about 10:30. So, and this normalized her TSH levels. Another 25-year-old patient notes persistent symptoms of hypothyroidism. She takes 75 grams regularly, and the T3 is 70, FT4 is normal, and TSH is 1.7. Now, you know that the normal levels of T3 are between 80 to 180. FT4 is somewhere between 0.8 to 1.8. So FT4 is normal, TSH is normal, the T3 is borderline low. I don't know if you see such cases often. And she said that her mother, when she is in the US, is being treated with T3. See, we treat with thyroxine, Euthyrox. Euthyrox has levothyroxine or T4. Now she said, why don't you give me this T3 also? So has anyone got any experience in treating with T3? And would you consider it in her case in this scenario?
No, sir, we are not using T3.
Okay, so hardly anyone has used T3, but I'm just going to tell you, since we get these so-called Google patients once in a while and they should be addressed, just remember that multiple trials have actually looked at this scenario of giving T3 with T4, but nobody actually recommends it. I'm not going to go too much into the detail. Just remember that we just treat with T4 and not T3. Okay, it's in very rare situations that we add T3, but I'm not going to go into them right now. Now, what about thyroid function tests in pregnancy? Remember that TSH changes in the first trimester. So if you're trying to screen in the first trimester of pregnancy, please do a T4 or TSH or FT4 and TSH. Okay, and now let's quickly understand what we are going to do for these patients. So can someone tell me, what would you do if the TSH is more than 10?
We'll
So more than
10, 10.
we'll start the
We have
treatment.
to start.
You have to
Yes, sir.
start the
We'll
treatment.
start the
Perfect.
treatment after 10.
Very good. So more than 10, there is absolutely no controversy. Okay. Now, what about between 2.5 to 10? What would you do?
So we start the treatment.
You will still start the treatment.
Yes.
Yes.
About
So that
2.5 will
means
start.
about 2.5 you will start.
Yes.
Okay.
Irrespective of symptoms.
Irrespective of symptoms. All right. Now, this is a completely separate topic altogether, and I'm not, it's a very different lecture. But let me tell you one thing. Even if you decide to start, the gynecologist who has sent this patient to you, the TSH was 3.8, and she has sent the patient to you. And she told the patient that, look, you have got a high TSH. I cannot guarantee the outcome of your fetus. There is a high chance that this patient will become mentally retarded. The brain development will not be good. But you go and talk to this physician. What would you say?
Do the TPO antibodies. Check for autoimmunity.
Wait. Okay, TPO antibodies. Let's say the TPO antibodies are negative. Then what will you tell her? Let's say the TSH is 3.8 and assume that the FT4 is normal.
Sir, I think there is no harm in starting the thyroxine.
You
But
will
if
still
you
start
don't
her on
start-
thyroxine.
Yeah, if we don't start, there is definitely probability of harming the fetus. But if we start it, I don't think there is any harm to the fetus or mother.
Okay, so at what TSH does the fetus get harmed?
About
About
2.
2.5. About 2.5.
About 2. About 2.
About 2.
2.5.
Yeah.
My God.
About 2.5.
So what the gynecologist told the lady is actually correct, because this was not detected till she came to you. So there might already have been harm, right? That's why she's saying, I can't guarantee your fetus. What will you tell the patient? Patient is sitting and crying. The whole family is sitting there in front of you. What will you say?
So start the TSH and observe.
No, that is fine. But what will you tell? What will you tell about the baby? You will start treatment is a different thing. Their question is very different. Will you advise abortion?
No, sir.
Why not?
Oh.
Why not? If you believe that this could harm the baby, and she is already in the third, let's say she is already 12 weeks pregnant, that means the TSH has been going on for 12 weeks. How can you ensure that the brain...
No, but sir, 12 weeks. See, there is no absolute baby will get means brain will be affected. There is no absolute data like this.
Absolutely,
So we should
but
not
you
advise abortion.
No, the patient is asking you, what about my baby? They are not interested in data. You understand what I'm saying?
Yes,
They
sir.
are saying, I have been told by my gynecologist that I cannot take any guarantee.
I think
Now
we have,
they have come to you.
First trimester has already passed away. We have
Yes.
second trimester to give thyroxine and cover up the.
But the brain development occurs in the first 12, 14 weeks only. It has started off. So how will it help to normalize it in the second trimester? See, I'm going to spend 5 minutes on this slide because this is my last slide, and I want you to go home with a very clear idea. I want you to tell me, it's okay. You say whatever comes to your mind. This is not an exam. Nobody is judging you.
So the probability
Sir,
of developing brain problem is very less.
Very less.
Yes.
Then why did this gynecologist frighten her? So my question is, at what TSH does the brain development become abnormal?
4.5.
4.5. I see.
3.5.
No, see, this is all very arbitrary, okay? So first of all, where have you read that the brain...
3.2.
No, we are just bargaining. This is not a mandi. We can't say की ठीक आहे तुमचं नाही माझं नाही 3.25 मध्ये संपवा असं नाही चालणार. So see, there has to be some science behind it. And where have you read? Which article are you quoting to say that a high TSH causes brain abnormalities in the fetus? So this whole thing started off, I'm not going to go into this whole lecture, But it is an article by Haddock, way back 20 years ago, published on retrospective data and published in New England Journal. What Haddock did was he just took records and he found people with TSH which was never treated, because at that time it was not thought to be very important. And people, in fact, avoided drugs in pregnancy. And in that group, the TSH lay somewhere from 8 to 100. And then he said that those people who did not receive treatment at the end of 3 years of life, the baby could have a IQ deficit of maximum 7 points. Do we know our own IQs? We don't. So if our IQ were to drop by 6 or 7, would we become mentally retarded? Never. So ultimately, what is now being said is that in India, any TSH up to 4 is okay. Between 4 and 10, people have still tried to see or differentiate between TPO positive and TPO negative, and nobody has really shown that if the TPO is negative, what really happens. Okay, but by and large, people are saying that if the TSH is more than 4, even if you treat, it will not do any harm. And the important point which came after Haddock's trial is that even if the TSH, forget 3 and 4, even if it was 30, if you quickly treated this patient, the chances of developing mental retardation are almost nil. So reassure the patient that this is a very borderline TSH. Nothing will happen to you. We are going to start treatment. We will normalize you as far as possible, as quickly as possible, and things will go right. So gynecologists are not reading their journals. I'm sorry to say this in a public forum, but I see 10 patients every day with such kind of rubbish being fed into their mind. It becomes very difficult for a physician to convince them otherwise. So do not make a big issue of this whole thing. Certainly go ahead and treat, but don't make a big hype of this whole scenario. On the other hand, there will be many patients whose TSH is borderline low. Just observe them. This is called gestational thyrotoxicosis. This is particularly seen in people who have morning sickness. They don't have hyperthyroidism, and do not start PTU or neomercazole just because the TSH is little low. Please observe in the first trimester, because these drugs are dangerous to the fetus. Is that very clear? So even if you err on the side of treating hypothyroidism, I'm fine. Please do not start anti-thyroid drugs for borderline cases. I hope this was adequately clear. Okay?
Yes, sir.
All right. So I think I'm going to stop here, and I am going to give this dais back to Dr. Erande to take this forward.
Phadke, sir.
After an excellent up and down from hypothyroidism, shades of hypothyroidism, and even venturing into hyperthyroidism in different patients, old ones, young ones, students, even the pregnant ladies, I believe sufficiently shaken as far as all of us are concerned. I don't know whether there are any particular questions in the chat box. Just give me a minute, Uday. I will try.
Sure.
Yeah, in fact, they are the responses to your questions up till now.
Okay.
So right now, there is nothing like an active question as far as the chat box is concerned.
Suhas, you're not audible.
I seem to be.
Yeah. Now you're fine. Now we can hear
Sir,
you.
Okay.
sir, can you please, will you please? Will you
Few
please tell
patients we
where
find
FT?
at fluctuating TSH. Few patients we find with fluctuating TSH at different readings.
Sorry. Sorry, I didn't get the question also.
So few patients we get fluctuating TSH at different readings at different times. Sometimes it is 20, then we start with the treatment, suddenly it comes to 2, again next time it becomes 10. Sir, have you seen cases? I have seen 2, 3 cases. Not understood.
So that is what I showed you, right? So while on treatment, the factors to be considered are adherence to treatment, whether the patient is keeping any gap between the meals, whether there are any confounding drugs that the patient is taking simultaneously, and of course, malabsorption. So all these factors are considered, and then the treatment is planned. But these 4 or 5 things absolutely must be taken. I have also seen TSH going high when patients have shifted to some vague generic drugs. Okay, I have seen this. So make sure that the brand loyalty remains the same. You use the same brand that was keeping the TSH normal. I think that is also very important. And I'm not just saying this casually. There have been trials on this in the US. When you shift from brands, there could be a TSH fluctuation also. So look at all these factors. And still, if you find that the TSH is fluctuating, well, maybe it's time to refer to an endocrinologist.
So how frequently you repeat TPO antibodies?
You never repeat TPO antibodies. It's done once, and that's it.
Sir, will you please describe the this one free T3 and free T4 to be done? What are the indications in short?
Sorry?
Sir, will you describe please indications of FT3 and FT4? In which conditions we need to do it? In short, if you can.
We need to what?
FT3 and FT4.
We need to do what?
FT3 and FT4, where usually we do not do, we do only T3, T4, TSH. But
So as I said, you don't need to do it except in certain scenarios. For example, nephrotic syndrome, where there is a severe protein loss. And because T4 is protein bound, you'll find that the T4 is very low. Actually, the patient is not hypothyroid. Once you take the protein binding out of the picture, you will find that the FT4 is completely normal. So if your thyroid levels based on T3, T4 and the TSH are incongruent, it is best to do a FT4 and a TSH. Otherwise, T4 TSH is fine.
okay, thank you.
Uday, I will rapidly try to read out the questions in the box.
Yeah, sure.
Questions on do any specific foods taken on a day of testing affect the test results?
Yeah.
Soy milk you have already
Yes.
yeah.
Yes. So I don't think so. There are slight differences between fasting and post-meal TSH, but the difference is not very significant. There is slight difference between morning and evening TSH, but again, it's not very significant. If you're finding that one of the factors is that if you're finding a lot of fluctuations in TSH, you could advise that patient to do a fasting TSH somewhere in mid-morning and stick to that. But usually the difference is not clinically very significant.
Yeah. And then, at what TSH would we advise terminating the pregnancy?
See, there is no such TSH value. The whole thing is a discussion with the patient. Now, if the patient is very severely hypothyroid and she is already in the end of second trimester, see, as it is, you will not be able to terminate the pregnancy unless you get a very special permission for that. There is no specific indicator, and even trials, as I told you, in TSH more than 100, if you start treatment and quickly normalize the patient, no society has given any specific indication for aborting this patient. As long as you explain to the patient what the risk is and that you're trying to normalize it, that's enough. There is no specific cutoff. And by and large, we do not advise termination to the patient.
Coming to the interface of diabetes and hypothyroid and hyperthyroid, are there any particular group of patients maybe where you palpate for a thyroid nodule, goiter, and then do the specific sort of test?
So in type 1 diabetics, I would do a thyroid test for all people.
Yeah.
In middle age to elderly age TSH, in women, it's always good to have a screening TSH because in that age group of menopause, hypothyroidism is quite common. So as a part of routine screening with all the other screens that we do for diabetes like A1C, lipids, etc., a TSH, and we find that very often, although there is no sort of relationship between hypothyroidism and diabetes of adult onset. So it's only in the autoimmune diabetes that we see that.
Right. And then there are some questions relating to monitoring of cases of old carcinoma thyroid post and on lifetime
That we will
thyroid
have to leave for
replacements.
this because it's a completely different, ball game altogether of how to monitor carcinoma thyroid. But I think we will have to leave it. I cannot explain it in one sentence. So there are too many ifs and buts depending on the type of carcinoma, on the spread, on age, on whether we have given radioactive iodine, etc., etc. So I can't give a one-line answer for this, really
All
speaking.
right, absolutely accepted. And how much maximum neomercazole dose have you given in?
We have used large doses of up to 200 milligrams also in very large goiters, which we were preparing for surgery. So they just wouldn't get controlled. And we have given large doses going on for 2 or 3 months, got them to relatively normal values, and then quickly operated on them. But these are uncommon scenarios.
Absolutely. I believe you have addressed most of the burning questions. And I thank you so much for an excellent, so I would rather call it as an excellent workshop of thyroid. You have taken us through very illustrious and still very common cases which we deal with, and with expression of thanks, which a lot of people have actually mentioned in the chat box also.